Your patient is having a seizure, and your first instinct is to put something in their mouth to protect their tongue. I need you to hear this. Do not do that ever, under any circumstance. You could break their teeth. You could obstruct their airway. You could lose a finger. Now, let me teach you what you actually do during a seizure, what you never do, and what happens after it stops. Because post-ictal care is the part everyone forgets and the NCLEX and your nursing exams loves to test. What do you do during a seizure? Your priorities during an active seizure are safety and observation. You're not trying to stop the seizure. You are protecting the patient while it runs its course. First, note the time. Look at the clock. The start time. You need to have a timer when the seizure begins. Timing matters because a seizure lasting longer than 5 minutes, it's a medical emergency called status epilepticus. That requires emergency medication intervention. And if you don't know when it started, you can't know when it's been too long. 2, protect the head. Place something soft under their head, a pillow, a folded blanket, your hands, if nothing else is available. The head is slamming against whatever the surface that it is on. You're preventing a head injury. 3, clear the area. Move anything hard or sharp away from the patient. Move furniture, remove glasses, clear the bed rails. If they're in bed, you're creating a safe zone around them. You also want to turn them on their side. This is important. During and after a seizure, the patient can vomit, drool, or accumulate secretions in their mouth. Okay, so side lying lets those fluids drain out by gravity instead of pooling in the throat and blocking the airway. This position is sometimes called the recovery position. And you do not restrain them. You do not hold their arms or legs down. You do not try to stop the movement. Restraining a seizing patient can cause injuries, fractures, dislocations, muscle tears. The muscles are contracting involuntarily, right, with incredible force. So let the seizure happen. Protect them from the environment. Don't fight the seizure itself. Now, here's a memory trick. You time it, you pat it, you clear it, you turn them. Don't hold them. 5 actions during a seizure in order. That's your checklist. What you never do now. 3 things that students and the general public confidently get wrong. You never put anything in their mouth. Not a tongue depressor, not a wallet, not your fingers, nothing. Patients do not swallow their tongue during a seizure. The tongue is attached. It's physically impossible for it to go down the throat. So forcing something into a clenched jaw can break teeth. It can cut gums, it can create an airway obstruction from tooth fragments or cause you a serious bite injury. So nothing goes in the mouth, period. Never restrain their movements, okay? Already covered, right? But it's worth saying twice because it's the most common instinct people have. The instinct is wrong. Never give food or fluids during or immediately after a seizure. The swallowing reflex may be impaired. So anything you put in their mouth could go straight into the lungs. Aspiration risk is high. You wait until they're fully alert and their gag reflex has returned. Now here's an NCLEX tip. If NCLEX describes a nurse putting a padded tongue blade into a seizing patient's mouth, that's the error in the question. That's the action you identify as incorrect. Despite what some outdated resources suggest, nothing goes in the mouth. Current evidence-based practice is clear on this. When to call for help. You call a rapid response or activate emergency protocols if the seizure lasts longer than 5 minutes, so that would be status epilepticus, the patient has a second seizure without regaining consciousness between them, the patient is injured during the seizure, or the patient has no history of seizures. This is new. The patient doesn't wake up within a reasonable time after the seizure ends. You also want to call. Now, here's an NCLEX tip. Status epilepticus is a seizure lasting longer than 5 minutes. It's treated with benzodiazepines. For instance, lorazepam IV is typically the first-line medication. It works fast to calm the electrical storm in the brain. Know that 5-minute mark. NCLEX tested. Now, the part everyone skips. Post-ictal care. The seizure stopped. The movements are done, but the patient is not back to normal. After a seizure, the brain enters a recovery phase called the post-ictal state. This can last minutes to hours. During this time, the patient may be confused, disoriented, They might not know where they are or what happened, okay? They may be extremely sleepy. You want to let them rest. This is normal recovery. They're experiencing a headache or muscle soreness. The muscles just contracted violently for an extended period. They're going to be sore, okay? Also, incontinent. Loss of bladder or bowel control during or after a seizure is common. You handle it with dignity. Your nursing priorities during post-ictal is to maintain the side lying position until they're fully conscious because of the aspiration risk, right? It continues until the gag reflex returns. 2, you reorient them gently. You're in the hospital. You had a seizure. You're safe. And you're going to do this calmly, simply, and you're going to repeat it as needed, because they're going to ask the same questions multiple times, and that's normal. Then you're also going to perform a neural check, assess their level of consciousness, orientation, pupil response, and motor function. You're going to compare to their baseline. You're going to document everything. You're going to document the seizure. This is heavily tested, okay? You're going to document the seizure. What to document? Time it started, how long it lasted, what the body did, which side started first, did it spread, what the whole body involved, or just one side where the eyes opened or closed. And here's an NCLEX tip. NCLEX will ask, which findings should the nurse document after witnessing a seizure? The answer is about what the body did, the type of movement, where it started, how it progressed, how long it lasted. These details will help the provider determine the type of seizure and guide treatment decisions. Documenting that you placed a tongue blade would be documenting an error. So remember, seizure precautions for at-risk patients. Now, for any patient at risk for seizures, with history of epilepsy, head injury, preeclampsia, alcohol withdrawal, electrolyte imbalances, we set up the room before a seizure happens, right? We pad the side rails on the bed. We have suction equipment ready at the bedside for secretions after the seizure, oxygen available, right? IV access maintained for emergency medication status epilepticus occurs. The bed will be in lowest position with wheels locked. We'll dim the lights and reduce stimulation if possible, especially for preeclampsia patients. We'll have sensory stimulation that can trigger seizures. We're going to pad the rail, stock the bedside, lower the bed. If the patient's at risk, prepare the environment before you need it. And here's a memory trick. Pad the rail, stock the bedside, right? Lower the bed. If the patient's at risk, prepare the environment before you need it. The seizure won't wait for you to set it up, okay? Nothing in the mouth, don't restrain, time it, protect the head, turn them on their side, and now after 5 minutes, it's an emergency. And after it stops, the care doesn't stop with it, right? Post-ictal assessment, document the action, right? And reorientation are just as testable as the seizure itself. Now, what do you do and what do you document after witnessing a seizure? Drop your answer. If you said what the body did, you're thinking like a nurse. Save this because seizures show up on the NCLEX and your nursing exams in neuro, in maternity, in psych, in med surg. Now, this video covers all of them. Watch it once to learn it. Watch it twice to own it. And I'll be right here when you come back. Think like a nurse, pass like a nurse. Happy studying.